Yeah.
Hi, Stefan and Hartmann here, Iron Direct Primary Care with Dr. Matthew
Not
Tinney,
Tinney.
Integrative Medicine of Brevard. And this is going to be a series on optimal lab reference values. So this is different than the standard of care reference values. You get a LabCorp Quest panel and you have these wide range of
Yeah, what's
values.
considered normal,
What
which
is
is,
considered normal?
yeah.
Now, where do they get these sort of lab reference? Where do they come up with this?
Well, basically, they look to see what's average for a group of individuals within a certain demographic, and then they base that on, the likelihood of whether they have a disease at whatever level. So, they were looking at vitamin D, low levels 30. So they say anything less than 30, you're prone to bone disease, rickets, things like that. So obviously, you don't want to be at 31.
No. So this is the kind of the stuff that we were taught in school. PA school and medical school. They showed us pictures. I remember African children with these bowed legs, and
Yeah,
they said this here is a bad calcium level.
right.
This is a
Vitamin D
very
deficiency.
low vitamin D. But these were very extremes. We learned about extremes of diseases. We didn't learn much about optimal reference
Right,
ranges there.
right. And in traditional medicine too, you're taught to treat the disease, not really to keep people necessarily healthy. So, sorry, it can't help you. You're not diseased yet. Come back when you have rickets, and then we can help you.
Yeah, when you start having symptoms of rickets, that's pretty far gone.
Yeah,
So what we do here when we see patients, we order the labs and we tell patients, they may say, hey, look, I'm in the green, I'm good, right? This may not be good for what we want for
yeah,
our patient.
exactly right. Yeah,
Right. So we'll talk about a couple here in this program. We're going to start with metabolic reference ranges that we look at. So when I see patients, I routinely order an insulin level on them, a fasting insulin level. I like this because it tells me how many carbohydrates the patient is eating, if they're eating a lot of processed foods, if they're eating a lot throughout the day,
yeah.
they're constantly
And you
feeding.
can look at C peptide levels too. That kind of is an average of what your insulin levels are producing, somewhat similar to what an A1C is to sugar.
Hmm.
So you can get an idea of what their average insulin production is. Obviously, if their sugar's high and their C peptide's low, they're probably not making enough insulin. On the other hand, if their C peptide's high and their sugar's high, then they probably have an insulin resistance problem. And giving those people more insulin to get their sugar down is only going to make their problem worse, not better.
This is important because what we want to do here is we want to prevent the patient from ever needing to go on insulin before they become
Right.
diabetes. We want to see this coming 30 years down the road. And so we have much tighter reference range values for this. When we see a glucose level, what would you like to see optimally in a blood sugar, fasting blood sugar?
84.
84, that's pretty tight.
Yeah, that's pretty tight.
Yeah.
For every point over 84 fasting, you have a 6% increased risk of diabetes within 10 years. So, standard lab says less than 100 is normal for fasting. But if you have a level of even 95, that puts you at a 66% risk for diabetes within 10 years. So, that
That's
may
not
not be
good.
the direction you want to go.
No. And for me, I like to see a fasting insulin below 5. So if you're 1.5 to 5 on an insulin level, you're a very high level athlete, you're eating great, you're
Mhm.
training hard. If your fasting insulin is above 5 or it's 10, it's 20, heck, I've seen it as high as 30 or 40. What
Oh,
does
yeah.
that mean when you're secreting so much insulin on a fasting test?
You're going to eventually burn out. It means the tissue is not accepting the sugar that your insulin is trying to promote. On the other hand, the fat and the liver are happy to take whatever you want to give it. I mean, it'll take as much as you want to give it. So that's where all the calories end up. People that are insulin resistant don't understand that it's not a matter of thermodynamics as far as like burning as much as you're taking in. It's really about where those calories are going. You could eat 800 calories a day with insulin resistance and you're still not losing weight because you're just tired because you're not burning anything, but all those calories go into storage.
Yep. That's why I try to emphasize to patients to grow their muscle, right? You can build
Yeah.
your muscle and make yourself more energy inefficient, right? You turn
Yeah.
yourself into
Right.
the Ford F-150 then rather than the Toyota Prius.
Right. Right. Exactly.
You start burning more energy throughout the day, but also your muscle becomes more intelligent. It functions almost like a pancreas. It works like an endocrine organ.
Yeah, your muscle will uptake the sugar without the effect of insulin during exercise. So, it'll suck it up because it has to have it to function.
Yeah, I tested myself at work continuous glucose monitor for a week. And one interesting thing that I learned is that when I played high level tennis, my blood sugar would go up. It would actually go up as much as if I ate a couple chai rolls or something like
Oh,
that.
really?
And the reason I think behind that is because my body is so well adapted at storing glucose in the form of glycogen because I do these high intensity exercises.
Mm-hmm.
So when I play an hour and a half of tennis, my body is converting glycogen, the storage
To
form of
glucose.
glucose, into glucose. So I don't pass out on the court. So I have a constant
Right.
stream of glucose in a match. But when I shake the hand of my opponent, I'm done. My blood sugar, it drops off immediately. It goes back to normal.
Yeah, that
Right.
makes sense.
And I explain this to patients as well. So the diabetic, when they eat 4 chai rolls, what will happen? Their blood sugar will go up to 200, and it'll stay elevated for hours. There doesn't go down for some
Yeah.
reason.
Well, your body doesn't know what to do with it.
Doesn't
It's
know what to
like,
do
should I keep this around? Should I have it in case of an emergency? Are you going to start exercising right now, or should I just go ahead and stick it into storage?
Yep.
So it just, it takes a while to compensate for that.
Right. What I found was, when I tested this out, I ate the chai rolls, my blood sugar would go up. It went up to about 130, but very quickly it would go back down. It didn't stay up very long.
Yeah.
My body knew what to do with the sugar.
Right. And that's really, when you're looking at A1C, that's your average, So if there's periods where your sugar's low, I mean, it may average out to look fine. This can be tricky because you're not considered diabetic per se until your A1C is over 6.5. But if you're running sugars in the 140s, 150s, but then alternatively you're running sugars in the 50s and 60s, it's going to average out to a relatively normal A1C, whereas in reality, you're in the beginning throes of insulin resistance because you're both high and low.
Mm-hmm.
So
another part of this insulin resistance pattern we see is the high triglycerides.
Yeah, exactly. Right.
The patients that drink the alcohols and eat a lot of the ultra processed foods.
Right. Triglycerides and uric acid is another one.
Yep.
That can sometimes be a sort of a predictor of insulin resistance.
But they told me back in school that uric acid was the king's disease because they ate too much steak.
Yeah. Well, purines, pyrimidines, things like that. But that's, rich man's diet, kind of just rich foods.
But we also know that the high uric acid is involved in the metabolic syndrome, the ultra-processed food diet, the diabetes, and the insulin resistance.
Yeah. So it's something to keep an eye on. I don't do it all the time, but, if somebody looks like they're headed in that direction, I'll usually get a uric acid just to help with prognosticating.
Now, do you order much of the NMR lipoprofiles or the cardio IQ?
A fair number, but I don't do them all the time because interventionally, a lot of it's genetic. So if people are going to take a statin or some other kind of lipid lowering agent, whether it's something that works in the GI tract or some kind of cholesterol absorbing agent or some omega-3s, that kind of stuff, we'll kind of track that. But really, I'm more interested in vascular inflammatory markers.
We'll get to that one next. So you don't have too much of a focus on LDL particle size or even LDL cholesterol in general?
We will, but if there's no point in testing it all the time.
Right.
Maybe once or twice a year at the very most.
So you found they're either genetically predisposed to high lipid particles or they're not?
Or they're not, yeah.
I found that too.
Yeah, exactly. And there's a lot of doctors I talk to that only test maybe every 5 years.
Wow.
Yeah.
Yeah, it is kind of falling out of favor, at least among our profession.
Frankly, I'm not convinced that cholesterol's the culprit at the scene of the crime either. I mean, you could argue that every time you go to a fire, there's the fire department, so they must be causing the fire. So just because cholesterol's present at the time of an incident doesn't mean that it's causing the problem. As a matter of fact, statistically, 50% of people that have heart attacks have normal cholesterol.
Yep.
So
that'll bring us to our next segment, which will be on inflammation.